Thank you. So this was the original talk I was supposed to give. I am the post-lunch speaker, and so nap time is right around the corner. Although there was hints this morning that what I was going to talk about was like, should schools be requiring vaccines, I actually took the mandate from the title that I was actually going to talk about my own experience as a pediatrician who deals with a lot of families who refuse vaccinations. So I should explain a little bit. I published an article that's included in the packet with a lawyer, Tim Aspinwall. And after I published this article, I thought that all the people who were refusing vaccines in the city of Chicago looked me up. And so it's interesting. I work at an FQHC, a federally qualified health center. So 80% of the children we see there are on Medicaid. And the other 20% are the University of Chicago faculty. So it's a very disparate group of children who have health care needs. And we were talking over lunch, and I mentioned that I've never had a vaccine refusal from a family who's on Medicaid, and that all of my refusals have come from my private paid and my highly educated patients, which reminds me of the first slide from yesterday, which gets back to the issue of the 1090 divide. And I just want to focus then on Siegelid's 3 points, that the reason we've missed, that bioethics hasn't really addressed it, is the misdistribution. And he said there are 3 reasons why bioethicists should really care about infectious diseases. Number 1, the significant impact of infectious diseases. Number 2, public health versus individual autonomy. And number 3, justice. Well, the justice issue was played out in the rotavirus vaccine that I talked about yesterday. But the issue of today is really about public health versus individual autonomy. And it's in this group, it's the individual autonomy, in my private, highly educated group, that this is where, in a sense, we address these issues of how much can the state require, at what point can we infringe on either individual autonomy or, more specifically in this case, parental autonomy. So, universal vaccination and exemptions. Clearly, the state has the authority to require universal immunization for infectious conditions in its role as parens patriae, or as the father of its citizens. But it's less clear, I would argue, how aggressively the state should use its power when the likelihood of infection is quite low. And as I mentioned yesterday, with rotavirus being so much more severe in the developing world than in the United States, so it's not clear then, when we have such high levels of immunity, when we really have these diseases at its lowest levels in history, when we actually have medicines and ways of treating most of the infections that if these children were to get, that we could avoid many of the morbidity, it's not clear how aggressive the state should be. And that's what I'm going to do, is try to figure out how we should balance this issue of individual autonomy versus public health. There are 3 types of exemptions. There are medical exemptions, if vaccinations would place the individual at risk. So a child who has ALL or leukemia, for example, should not be getting live virus vaccines, so we wouldn't require it of them. And there are religious and philosophical exemptions. And while these change, the fact is in the vast majority of states, parents can get religious or philosophical exemptions and therefore avoid vaccinating their children. So one of the big issues that I think Doug Diekema addressed, as well as Joel Frater this morning, is whether failure to vaccinate is medical neglect. So clearly, failure to immunize children against certain diseases when a safe and effective vaccine exists is medically neglectful. Of course, we could argue then, at what point does a vaccine reach the level of safety and efficacy that I would call it neglectful not to give it? But even if I'm willing to call it neglect, the issue still is, what's the threshold for legal intervention? The fact is, if you put a child in the car on a rainy night, Doug, rather than just on a clear sunny day in Seattle to go to Starbucks, it might be more neglectful. And if you were to violate the speed limit, it might even be a little bit more neglectful. But the question is, at what point do we really want to involve the state? And the fact is that most of us really believe that the state should be, in a sense, an organization, an institution of last resort. That to the extent we can avoid state intervention, we would all be better off. So Goldstein, Freud, and Solnit wrote a book called Beyond the Best Interest of the Child, and their argument that the state should only be involved when it's the least detrimental alternative. That when the state is a very blunt instrument, and so we should only involve them when we know that it's better than the alternative. And so they wanted to use 3 criteria. Number 1, that the treatment is of proven efficacy. Number 2, that it has a high probability of success. And 3, that denial of treatment will most likely result in imminent death or serious morbidity. So vaccines are troublesome because usually vaccines aren't about imminent death. I actually describe it when talking to families that are refusing vaccines of playing Russian roulette. And depending on the environment, depending on the level of immunity in the community, will depend on how many bullets are in the gun. But the fact is, it's a game of Russian roulette. So the probability of anything bad really happening to a child in Chicago for refusing vaccines is very low. So if we call it 1 or 2%, there are 1 or 2 bullets out of 100. In periods of epidemic, it's going to go much higher type of thing. But then I also point out to these parents that percentages mean nothing. It's 0 or 1 for your child. If your child stepped on the rusty nail and it does have spores for tetanus and your child's not immunized, it's going to be a bad outcome. And I can't predict it, and you can't predict it. And so what you're doing is you're playing this game. And it is just a statistical probability, but it's 0 or 1 for your child. I would also argue that whether neglect is due to sincerely held beliefs, whether they're religious or philosophical, shouldn't matter. Although I would argue that both of those deserve much greater respect than neglect due to inconvenience, laziness, and things of that sort. So the real issue for this issue in infectious diseases is not really about justice. It's about balancing public health and the community's well-being and individual freedom. Doug's talk about whether parents have obligations, not just to their children, but to the community at large, is one that is very controversial. So it might be that we could agree that we all have obligations to not only ourselves, but to the community. But the issue of whether a parent has an obligation beyond looking at their own child's best interest, that in some ways they should even allow their child to be exposed to some risk for the greater good, I would argue is a much more controversial statement because parents have obligations, if not fiduciary, but at least clear duties of parental responsibility toward their children. So this whole issue, the state, though, has an obligation to ensure that all non-exempt children are fully immunized according to public health recommendations. So a child who doesn't meet their medical exemptions, their religious or their philosophical exemptions, the state has an obligation to try to get these children immunized, which would require improved access to such services. I would also say that state intervention then becomes justifiable in times of epidemics, regardless of religious or philosophical objections. So what I wanted to do today was actually look at these issues by using case studies from my own practice of individuals who have refused and how I've addressed it. I've never dismissed a patient. I can't imagine a scenario in which I would, but I'm sure there are plenty of parents who have dismissed me. So we'll leave it at that. So the case one is an immunization refusal. Mr. T brings in his son Tommy for a preschool physical exam. Tommy is 5 years old and will enter public school in September. Tommy recently moved from Ohio and has not received any immunizations. His parents base their refusal on religious grounds, and the fact is that most states are going to respect this religious refusal. And the question is, what do you do next? Well, I live in a state that respects religious refusals. And so here I look at the article by Erin Flanagan-Kligas and Sharp and Frater, who are here in the audience, which their study had 1,003 pediatricians from the American Academy of Pediatrics. And what they found was that 85% of physicians reported encountering partial vaccine refusal during the preceding 12 months. And Doug has already told the story of his own refusal of the varicella vaccine. Doug and I have children who are approximately the same age, and I have to tell you, I also didn't give my child the varicella vaccine at the recommended age. So we're going to find out that a lot of those refusals may actually be coming from healthcare providers as well. 54% reported encountering a parent who refused all vaccines. And their refusals were, as we've heard, the safety concern, the thimerosal, the mercury experience, too many at one time, and philosophical or religious objections. And what they found was that for parents who were refusing specific vaccines, 82 of their respondents, or 28%, said they would ask the family to seek care elsewhere. And for the parents who were refusing all vaccines, they found that 39% would refer the family. And the reasons the physicians gave for their position was lack of shared goals, lack of trust, fear of litigation. But some said that the type of vaccine refusal was extremely important, that the older vaccines, in a sense, the DTaP, the Hib, the MMR, and the IPV, were more important than the pneumococcal, the Hep B, and the varicella vaccine. And I thought this was very interesting. So a lot of what we were seeing wasn't this just mass refusal by the parents, but we were also seeing that it wasn't just a mass dismissal by the physicians, that they were thinking to themselves, where am I going to draw the line type of thing. Doug Diekema, who worked with the Committee on Bioethics to come up with the statement of responding to parental refusals of immunizations that was published last year, cited other data, as Joel Frater already pointed out, which was very similar, which found that 7 of 10 pediatricians reported they had a parent refuse an immunization in the last 12 months, and it was usually MMR due to the fear of autism, but there was also refusals of varicella and pneumococcal, and then Hep B. And 4% of the pediatricians stated that they refused permission for an immunization for their own children younger than 11 years. Now, I don't know if Doug and I would count in that, because eventually both of our children were immunized for the varicella, but there was a delay. And finally, the data that Doug published in this statement in the American Academy of Pediatrics was that a small percentage of physicians, less than 5%, but sometimes up to 18%, tell parents they will no longer serve as the child's physician. And I think the panel this morning was pretty clear. Just because they refuse vaccines shouldn't be a reason to dismiss a family. It really should be a much more global distrust and anger within the doctor-patient relationship. The AAP Committee on Bioethics statement then went on that the first response of most pediatricians should be an attempt to educate. And educate doesn't mean with a sledgehammer. You just don't keep hitting them until they agree with you. But they were also very concerned about liability and said that it should be documented when families refuse. And they actually suggested in this article to consider 3 types of cases. So the first type of case being cases in which refusal risks harming the child sufficiently that the decision constitutes medical neglect sufficiently serious that it justifies DCSF involvement. And so they used the example, appropriate that Doug used the example today, of refusal of tetanus after sustaining a deep and contaminated puncture wound. Then they talked about another level of cases, which would be cases in which refusals put other children at risk of harm, sufficient to justify public health intervention. And here they looked at, for example, the measles immunization requirements for school entry. And then they listed the next set, like hepatitis B, which is really not about developing herd immunity, but is really about protecting the child as a teenager and young adult. And the AAP also said, so after you sort of evaluate at what level the refusal is, you should then listen carefully and respectfully to the parents' concerns, recognizing that parents may not use the same decision criteria and may weigh evidence very differently. They said educate them. So, for example, the risk of encephalopathy from a measles vaccine is real. It's about 1 in a million. The risk of encephalopathy from measles itself is about 1,000 times greater. So this, again, it's all about weighing the pluses and the minuses and the balance. Negotiating, so some parents may want to delay MMR until 3 years because of the fear of autism, and I have seen that quite a bit, particularly in young boys. Continued refusal after adequate discussion, the AAP said, should be respected unless the child is put at significant risk of harm, so during an epidemic. So it was interesting that, I think it was Erin in the panel said, so after the measles and mumps epidemics occurred, that many people called up to get their MMR vaccine. I actually have a very different policy with my families. I tell them I keep their name, addresses, and phone numbers in my desk, and if there is an epidemic, I'm calling them. Because at some point it may be that while I respect their refusals, it may be at some point that I do consider it's so dangerous for the child that I am willing to get state intervention. And I actually tell that to families, because if the families don't want to accept that as my prerogative, then they should know, and maybe this isn't the relationship that's going to work. So while I'm going to respect many refusals, I do keep track of who's refusing the vaccine so that if necessary, I could go and contact them during an epidemic. And the AAP concluded, though, in general, pediatricians should avoid terminating relationship. It allows for continued discussion. And I do think that with continued discussion, many parents do eventually come to accept immunizations. And then they point out that even if you can't convince them of that, the child still deserves and needs access to medical care for other health problems, and better for them to be in the system than to be outside. So what did I do with Tommy? I accepted him into my practice. I explained to these parents the limits of my willingness to respect their refusal, that there would be public health threats, and that I did keep a list of names of all who refused and what vaccines they refused, and that if their decision placed Tommy at serious risk, they'd be hearing from me. And I continued to engage the parents in discussions about immunizations, and actually this past year, they actually did finally agree to start the DTAP series. He's 9 years old now, because they're planning to go on a camping trip. And I tried to suggest to them, you know, if he really did get this cut on the rusty can that somebody was negligent about not cleaning up in the campgrounds, and they ended up in an emergency room, we'd be talking about doing it there. And wouldn't it be better to have their kid protected so that they can continue on their camping trip? And that seems to have worked. But that's the only vaccine that Tommy has gotten so far. Here's a different case. This is Mrs. V, who brings in her daughter, Violet, who's 7 years old. She's been homeschooled, and so mom has avoided all immunizations because she wanted her daughter to be part of the decision-making process. This one just gave me a headache. I mean, the idea of trying to convince a 7-year-old that she really wanted needles and how many needles just didn't seem like it was going to go well. But she actually agreed to 2 needles. And so the first question is, should you work with this family? And I think it's clear that everybody on the panel this morning and myself would say yes. And then comes the question, can you work with this family? A very separate question. But Violet and I were going to have this great conversation. And so what questions then? The question is, so I have 2. She's 7 years old. She's never been vaccinated. And this is really for those of us who are practicing clinicians who work in public health. If you only know you're going to get 2 needles today, what are you going to negotiate for? MMR. And? Okay, so let's see what I did. So at age 7 years, I thought Hib and Prevnar are less necessary because the risks are much higher in younger children. And I thought hepatitis B vaccine can surely wait till the child's a teenager, or at least a little later. It wasn't on my top 2. And then I said, well, are you going away for travel or foreign exposure? Because I thought if they were going to Nigeria, Afghanistan, or any of the places which had active polio, I would be putting that high on my list. But if the family lives in the US and isn't planning to go outside of the US and does not have an international nanny, one can probably wait on the IPV. There is a recent outbreak published in the CDC MMWR of a recent outbreak in an unimmunized community in Minnesota. So that it's not that it's impossible, even if they're not planning to travel. And then I also thought to myself, if one is not planning to go on a camping trip or walk barefoot in city parks, the tetanus can probably be safely withheld too. And if necessary, it can be given with up to 72 hours post-injury. So then I also wanted to know about household members, because if a family member has severe COPD or asthma, I might want to be thinking about influenza, even if it's not for Violet, for the well-being of the whole family. So what did I end up doing? I ended up in order of importance, MMR, I agreed with everyone in the audience. DPT, I agreed with everyone in the audience. Knowing that I wanted to complete a series, Violet and I had to talk about how frequently she would come back in and how many needles we could agree to for each visit. And I thought it was really important to mention that especially with the DPT, if she doesn't come back for 6 months to a year, it's okay, in contrast to Hep A, where the guidelines really say you have to give the second one in less than a year. So it seems like we're all on board, MMR and DPT, and that's what I gave her. Here's my third case. Ms. H brings in her twin children, Helen and Henry. They are why people need to have the same letters. Helen and Henry, they are both 2 months old. They were born at a birthing center and received no immunizations, but they did receive vitamin K. When Ms. H learned that I wanted to administer DTaP, Hib, Hep B, IPV, and Prevnar, and now I would be adding rotavirus, she became quite distressed. And so she asked me how many vaccines will her children need by age 2 years. And I think that went over very well. This morning, the answer is 20 plus 7, just up until that age, right? So we have the 4 DTaP, the 4 Hib, the 4 Prevnar, the 3 IPV, the MMR1, the varicella 1, the Hep B3, and possibly, depending on what the recommendations in their community, Hep A2, 2 doses of influenza by that point, and of course, reintroducing the rotavirus for another 3. And if you count DTP as 3 different diseases, the answer is 11 diseases plus 3 or 14, and that's before the age of 2. We haven't even gotten to the adolescent vaccines. So if you count the number of times each disease requires an immunization, you're at 30 plus 7. That's a lot. So I have a distressed mom. She asks the question. I start writing this out. And she just looks at me and she says, I'm willing to authorize the immunizations for my children, but can they be delayed? Because I'm really concerned about the fear of autism. And we talk about the thimerosal, we talk about the relationship with MMR, and we talk about what are the risks and benefits of delay. And I think, again, here it's important that I live in a city which has a very high immunization rate. And so the risk of delay is much less than it might be elsewhere. And so the question came, if I had to delay, which ones am I more willing to delay? So which ones do I really want to give to this 2-month-old? DTaP. Hib and Prevnar. All right, those are the ones. So if I can only immunize for certain diseases in infants under 1 year, I would pick, in this order, DTaP. And more for the diphtheria and pertussis, I would argue, than for the tetanus, Hib, and Prevnar. God, we are on agreement, or you're reading ahead. All right. My 4th case is an issue of school entry. So this was actually a principal called me up, and she said that she's the principal of a private school in my area, and she wanted to meet with me. It's a Montessori-type school that admits children from age 1 year on. It's called the Mommy and Me program, but since my husband actually took our own kids, he loved calling it Mommy and Me, but they insisted that he should be calling it Caregiver and Child. And they allowed children into the full nursery program at 2 years of age. And the principal wanted to know whether she should allow unimmunized children into the program. So, can the school require immunizations for school entry? The answer is they can. Must the school respect religious or philosophical refusals? That's actually very dependent upon state laws. So sometimes the refusals are more permissive in the private schools than they are in the public schools. And if the school does allow children who are unimmunized, do other parents have a right to know? So I might want to know because my child is getting treated for ALL, or I might want to know because I don't want free riders in my midst and things of that sort. And does it matter for the rights of the parents who are immunizing their children? Does it matter to them? Do they get to know if it's only one child who's unimmunized or if it's up to 25% of the children in the classroom? And this raises issues then of herd immunity and the greater likelihood of spread when the level of immunity in the community goes down. So we had this really very interesting discussion, and so I guess my question is, what recommendations would you have from Ms. C if she does decide to allow unimmunized children to attend her school? So I thought the most important thing she could do was have a clearly written policy so that all parents would know what the policy was, and then they could make decisions whether, particularly for those who are going to immunize their children, whether they wanted to have their own children exposed to a potential epidemic at a greater rate, given that unimmunized children were allowed at this school. And here are the issues I thought her policy needed to address. What will be done if a child comes down with any of these conditions? To whom, for example, will cases be reported? Was Ms. C going to keep that same list that I did so that if a measles epidemic broke out, she would call these parents and say, 1, you can't bring your kids, but 2, I'm calling the public health department? Is there a maximal number or percentage of unimmunized children who can attend the school? Could she and her colleagues could make a decision of what percentage, at what point does it put all the other children at risk? I also should be very clear about what right parents have to know about the policies and about the percentage of unimmunized children who attend their school. And what happens if a child or a child sibling develops an underlying condition, such as cancer, and the treatment leaves him immunocompromised? Will the school defend the right to refuse or the right to community protection? So these were issues she and I had to discuss as she was writing up her school policy. I have to tell you, I've tried to reach her. I mean, I have reached her. I know that she's still thinking about it, but we don't have a school policy yet in place. But I should also tell you that it's only been one kid, more or less a year, that has actually approached her about this. And she's not feeling the pressure that she might feel if it was a larger or contingent group. But then, that was, Mrs. H asked us about how many vaccines we were going to give to her children before the age of 2. I think we also have to address the issue of adolescent vaccines. And currently it's Tdap or at least DT, so 1 booster dose. There's the Menactra, which was previously being recommended for children entering college and now being recommended for children entering middle school, although with a couple of cases of Guillain-Barré, there are some people who are still delaying it until college. There's Hep B, if not previously given, the series of 3. There's varicella that, if again not previously given, will now require 2 vaccines, and influenza in teens with chronic health conditions or who live in households without risk members yearly. So these kids are getting vaccinated a lot. So when these parents come in concerned about it, the answer is we really are giving them a lot of immunizations. I don't think it's a dangerous thing, but if they're concerned, when we start talking the numbers, you can see their level of anxiety just rising. And of course, in the near future, HPV vaccine for sexually transmitted infections, a series of 3, and the hope for herpes vaccine. So lots of adolescent vaccines. So Ms. M comes in with her teenage son, Mark. He's a nationally ranked squash player and is being recruited to attend boarding school in the East Coast. The school requires that all entering students have received Menactra in the past 5 years and Tdap, and that they be tested twice for tuberculosis. He needs 2 vaccines and the first of 2B tests. Mom says, okay, go ahead, and Mark says no. So what do? So the first thing I do is say, so Mark, why not? And because if it's fear of needles, for example, I can use Emlacrine, right? If it's a philosophical or religious belief, and it might be, because Mark then starts explaining he's a vegetarian, he believes in meditation to achieve holistic well-being, and so now it starts getting into the issue of how strongly does he hold these convictions, and is he, for example, willing to forego his scholarship to boarding school? And then came the issue of whether I was willing to call the school to see if an exception could be made. So this was a huge set of issues. But then Mom looked at me and said, does it really matter what Mark thinks? So I told you, go ahead. Mom's not a vegetarian. Mom doesn't believe in meditation. And so, it's an interesting thing. None of us think twice about holding the 15-month-old down to give the MMR and the varicella and the Hib. But are we all willing to hold down a 15-year-old who's actually bigger than we are, right? So, and then part of it is you really need his active assent, because this isn't about research, this is about therapeutic clinical care. So it's one thing if I have to hold him down, but what if he's screaming no, 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 and he's crying, but he puts his arm out and he doesn't sort of move away? Is that enough of an assent, and do I really need the assent of an adolescent? And so I do think that we have to think about this. So I look at Mark, I look at his mom, and I say, let's try to figure this out. So the deal was, Mark actually at 6 months before he had to go to boarding school, his mom and Mark agreed that they would negotiate this at home and come back. And I gave them numerous references and website addresses. I specifically recommended AAP website. Somebody asked today where they can go, AAP website, CDC. And I specifically discussed the Waxman scandal and the Lancet, because a lot of times when you do hit Google and you write immunizations, there's a way of writing your web page to ensure maximal uptake. We think marketers do that, but it seems that some of the anti-immunization crowd also knows how to do that. So the first ones that will often come up will be some of the arguments about MMR and autism. So I specifically mentioned it to them. I gave them the articles. I gave them the retractions and things of that sort. So that wasn't, when they found those articles, they weren't going to be, see, she lied to us. She didn't tell us about all these risks. I told them that they could either call me or they could just call for a nurse visit. Turned out Mark was really scared of pain. And I have to say, I've had a lot of teenage boys, football players who come in crying over vaccines, but he was a squash player. We did order EMLA for him. It was incredible. By giving him the power to have EMLA cream, he was willing to take all of his vaccines at the same time, and we could update his school form. What would I have done? I probably actually would have called the school to find out if they would have made an exception. And I hope they wouldn't have made an exception just because he was a phenomenal athlete. I really hope they would have made the exception because they actually believed that if a kid held these strongly philosophical beliefs, that should be respected. I don't know, but I didn't have to go there. So my whole I guess everything I'm going to say about today is all of this needs to be a negotiation. And the more you're willing to listen and to hear families and to respect their values and to be a part of a team player, the more that you're going to get some amount of agreement. Now, not full, right? I mean, the first case, I'm still on the second DTaP in a 9-year-old, right? And that's the only immunization the kid has gotten to date. So childhood vaccines, are there limits? Are more better? From a public health perspective, more seems better. From the perspective of the individual patient's medical well-being, I would also say that more seems better, although some individualization may be appropriate. From the perspective of the provider, uniform policies are easier than having to negotiate each set individually, particularly when you're trying to negotiate with 7-year-olds. And then you have to get into what populations, what age, the timing of the vaccine, particularly if it requires multiple doses. Can you negotiate with the family in a sense, okay, if we start this one, I really need you to come back in 2 months or 4 months. And then you have to get into the whole issue from the perspective of the provider. It's a lot easier to do Hep B in the newborn at 2 months and at 6 months. But the fact is, for many of these highly educated parents who would and could bring their kids back at age 8, 9, or 10 before they can become sexually active or using drugs, it's really, I would argue, that Hep B we're doing in the newborn period is a matter of convenience for the healthcare providers. And that if we had a system of bringing back older kids and early adolescents, that it wouldn't be as necessary. And so I am very much willing to work with families, for example, on that one. So childhood vaccines, are there limits? I think limits should be based on absolute risk to the child, risk-benefit to the child, as well as risk-benefit to the community. Parents can refuse, provided it is not seriously and imminently neglectful of the child, and I think we really have to talk about a balance between respect for parents to raise their children according to their own values and the well-being of the child. Parents can refuse also, provided it does not pose serious risk to the community. And here then we have to start balancing respect for family autonomy as well as community well-being. And sincere convictions, whether religious or philosophical, should have greater weight than objections do to inconvenience or laziness. So are there limits? I would argue, like Doug, if the state is going to mandate these immunizations, that there may be obligations, for example, to ensure safety. So we need vaccine databases. We need post-marketing surveillance, or what we call phase 4 clinical trials. We need maybe stricter reporting laws to VAERS on the part of healthcare providers and the public health department to ensure that we really know how safe these vaccines are. I would agree with Doug that we probably should be providing these immunizations free of charge if we're going to mandate it. There should then also probably be compensation if an adverse event occurs, and that we should continue to track potential long-term risks of both individual vaccines as well as the combined multiple vaccines. So I hope this was helpful, and thanks again for inviting me.